Giacomo, please tell us.
Thank you very much. Thanks once again for the invitation. So these are my conflicts of interest, which are not really related to this talk. However, I have a more personal conflict of interest. Most of the data I will be showing you today come from the LungSafe study, which has been a great personal and professional experience. So I would like to thank the members of the steering committee with me and the SICM, whose president happens to be on the stage, and all the LungSafe investigators. So if we look at the story of non-invasive ventilation, I think a very interesting paper is this one, published by Alexander Demur a couple of years ago, where the investigator looked at something quite simple, which was the trend of the use of NIV as a first-line intervention during different types of respiratory failure. So here you have the three cohorts of patients in the three gray, light, and dark bars. And as you see, already there was a very high use of NIV on acute on chronic patients, and this increased over the years. And this also, the use of NIV also very much increased in cardiogenic pulmonary edema. If we look at the cohort of patients which the authors carefully called de novo respiratory failure, as perhaps not all the criteria for ARDS were fulfilled, but that basically includes most or all, a lot of ARDS patients. As you see, the clinicians are a little bit more reluctant in using NIV as a first-line intervention on these patients. And I think this reflects two aspects. One is the lack of literature data that solidly favors or rejects the use of NIV data, and the other one is that perhaps clinicians are using NIV in cardiogenic pulmonary edema, see that it works quite well, and so they are more inclined to use it in the next patient, whereas the results are not as good for ARDS. So if we look at the literature also, there is not really much published on this topic. You see, we have 136 papers overall. If you look for non-invasive ventilation in ARDS, 30% are review articles. So we are left with, I would say, rather small, very well conducted physiological studies, some observational larger studies, but still the amount of evidence we have in this field is quite limited. Luckily enough, this summer, a task force drew some guidelines for the use of non-invasive ventilation for acute respiratory failure. As you see, there's a great lineup of experts who put down these guidelines. So let's go, and now we have guidelines, let's go and see what they say. There is a whole list of disease listed here by which the experts had an opinion and a recommendation, but for de novo respiratory failure, ARDS, they have no recommendation. So thank you very much, experts, for this. So I think at this stage we are left with what is the common sense, what is our daily clinical practice, and some information we can get from the literature. Some data is out there. It's not like evidence-based recommendations, but still we have some data there that could help us. So as I said, I would like to start a little bit from the LungSafe results. And when the LungSafe study was designed, we explicitly decided that we would have had a sub-study devoted on NIV, non-invasive ventilation, because we realized, the steering committee realized, that really there was not so much data available on this topic. So we wanted to understand what is our current clinical practice on this field. We wanted to sort out a little uncertainty which is in the Berlin definition, but I will not get into this. And especially, we would like to establish factors associated with NIV failure and death that could be tested in future RCTs. This is just an observational study, so we will never be able to claim a cause-relationship effect, but at least we could generate some hypotheses. So we, as you perhaps are aware of, we started with a fairly large cohort of almost 3,000 ARDS patients, and we then focused our attention on these patients who were treated with NIV. And I think we did not emphasize the message clearly enough in the paper. When I talk to people, I realized there is a little bit of confusion on how we defined patients being treated with NIV. So for the rest of my talk and in the LungSafe paper, the patients that are assigned to the NIV group are those patients who were treated with NIV on day 1 and also on day 2. So these are patients, we reasoned that those were patients in whom clinicians decided to use NIV to try and treat them. Whereas these patients in whom NIV was only used in day 1 are classified in the invasive mechanical ventilation, because we thought these could be patients just coming from the floor, coming from the ER, just received some CPAP while intubation was getting ready, and so these are not really patients treated with NIV. So I think it is important to keep in mind that LungSafe does not address the question of NIV as a very first line intervention. It looks at prolonged, if you may call 24 hours prolonged use of NIV. So I think this is an important point to keep in mind. And as you are aware of, the experts who participate to the consensus conference for the new Berlin definition of ARDS have proposed a series of adjunctive treatments to be used in ARDS patients. And as you see, they suggest, in yellow means that the suggestion is weak, but at least they have a suggestion, in mild ARDS patients. And this is what we had expected to find, right? Most NIV use in mild ARDS. However, when we looked at the incidence of NIV use, what we found was that pretty much 15% of the patients were being treated with NIV, but there was no real difference between mild, moderate, and severe ARDS. However, sorry, I'll go back to this slide in a minute. However, when we look at the failure rate, we must be prepared when we decide to use NIV on a mild and on a moderate and severe ARDS. We must be prepared to face almost 50% of failure. So every other patient will require intubation. And clearly you can look at the glass half empty or half full, because you could also say, well, 50% of the patient will make it without being intubated. The problem is that you are exposing all your patients to NIV and you don't know, or you can only have some guess on who will make it and who will require intubation. The big difference between the main difference between the use of NIV and non-invasive ventilation regarded non-pulmonary SOFA score, so patients with more pressors, greater renal failure required, were most oftenly treated with invasive ventilation. And I think this brings us back to the idea of common clinical sense. If your patient is on pressors, needs to receive RRT, most likely you would like to have this patient intubated. We also are aware of the fact that if we decide to use NIV, we will expose our patient to the risk of delaying intubation a bit. And there are some studies out there showing that if you wait and intubate your patient not right away, but you wait during the first 3 days, the mortality rate of patients receiving a late intubation will be higher than those immediately intubated. And it's interesting to notice that the mortality is not related to the intubation per se, but occurs even later. Clearly, patients who fail NIV will have a much higher mortality rate than patients treated right away with mechanical ventilation. We are super selecting patients whose clinical condition is declining. This does not mean that failing NIV causes mortality, is associated with mortality. So, until when shall we use NIV? we looked at in a propensity matched analysis in our cohort, and what we found was that if you look at the panel in the middle, patients with a PF ratio below 150, NIV used, again, not as a first-line intervention, not as soon as you receive the patient from the ward, but used for the first 24 hours, was associated with an increased risk of death, which was statistically significant. Whereas if the patient had a higher PF ratio, our data seem to suggest that NIV is safe and is not associated with any increased risk of mortality as opposed to invasive mechanical ventilation. And once again, this is an observational study, so some biases are there which we've tried to tease out by this propensity matched approach. And perhaps in this patient, you can take advantage of having the patient away, talking to his or her family, without the need of intubating this patient. It is, however, important to look at what the evolution of the patient is. This is our multivariate analysis for factors independently associated with NIV failure. And as you see, we had PF ratio, which is a strong predictor of NIV failure, but also the change in PCO2. If the PCO2 is increasing, the patient is more likely to fail. So we need to follow the patient strictly, more strictly I would say, if the patient is on NIV as opposed to invasive ventilation. And this was shown by Massimo Antonelli in one of the earliest publications on the use of NIV in ARDS, where the group has shown that in patients who would fail NIV, there was an initial improvement in PF ratio, but then the PF ratio declined, whereas patients who succeeded NIV were those patients in whom PF ratio kept increasing. I'll skip this, but we had the same result in the lung safe. Finally, I think it's important to keep in mind that we need to protect the lungs of our patients. So if you look at the PCO2 trend in our patients, those who were non-invasively ventilated, here in red, had a decrease in PaCO2, the most severe their lung condition was. These patients felt like they were dying. They were hypoxemic, their lungs were stiff. They didn't read the book of ventilator-induced lung injury, didn't come here to listen to the talk, they just wanted to survive. So they did breathe as strongly as they could, and their PCO2 dropped. Is this relevant for lung injury? I think it is. And I think it is because Guillaume Carteau and the group of Meconza Dessart have shown that, for example, one of the predictors of NIV failure is mean expired tidal volume during NIV with an odds ratio of 1.3. Again, PF ratio is there. And as you see, both in mild hypoxemia, but especially in moderate to severe hypoxemia, a high tidal volume is greatly associated with the risk of NIV failure. Is this what is causing what? We do not know. But certainly, a patient on NIV with a very high tidal volume is a patient you should very, very carefully think of intubating. So getting to the conclusion, non-invasive mechanical ventilation, until when? Honestly, I don't know, but no do the experts, so maybe this makes me an expert. So I think we have no major concerns if the PF ratio is above 150, and in the most severe patient, I think it still makes full sense to use it as a first line, but we should absolutely monitor gas exchange and tidal volume, because these patients are at high risk of NIV failure and death. Thank you very much for your attention.